Welcome back to the Journal of Marital and Family Therapy's Decade in Review video series hosted by the American Association for Marriage and Family Therapy. The special Decade in Review issue is the fourth of its kind over the years and assesses the efficacy and effectiveness of couple and family therapy by reviewing rigorous studies published over the 10-year period from 2010 to 2019. The findings from this special issue show the tremendous progress and achievements made to date, inspiring our continued commitment to making marriage and family therapy and interventions widely available. For this episode, the authors are taking over JMFT and will be focusing on our article on couple and family interventions for high mortality health conditions. My name is Dr. Angela Lamson, and I am joined today by my co-authors, Dr. Jennifer Hodgson, Dr. Tai Mendenhall, Dr. Jackie Williams Reade, and Ms. Erika Taylor. Thank you all for being here today. To begin, I would like to set the stage and tell you why we are invested in this topic. All of the authors on this manuscript identify as marriage and family therapists and medical family therapists, which means we see health, illness, loss, trauma, and well-being in the context of families and how they interface with larger systems such as healthcare. For this article, we focus specifically on an evaluation of efficacy for couple and family interventions with a focus on the most prevalent health conditions that lead to mortality in the United States. Our aim was to provide a review of the empirical support for couple and family interventions in context of specific health conditions in order to better prepare family therapists to provide best practices to couples and families across the lifespan, regardless of the therapist's work context. This work is important for therapists in private practice, as well as in primary, secondary, and tertiary healthcare systems. This brief introduction leads into an important question from my colleague, Dr. Jennifer Hodgson. Jennifer, the concept of health can mean so much to so many people. Could you talk a little bit about how we narrowed down what to focus on for this study?
Sure. So I think when we sat down to really think about what health conditions would be most helpful for family therapists to know about, we looked at the CDC's top high mortality conditions. We wanted ones that were going to be most commonly occurring across our country. And we looked to see what were the top 10 among adults, and then the top 3 among infants, children, and our youth. So from there, we then went through a pretty rich methodology, and we will talk more about that to come. But we took those health conditions and really landscaped the literature across them to see what had been done. While suicide and homicide were definitely included as top mortality conditions in every age category in our review, they weren't in this article because they were reviewed elsewhere in another review. So we also included something that didn't necessarily occur in the top 10, but is widely recognized as a top mortality condition, and that's obesity. What is the issue with obesity in our country? It's oftentimes a precursor to many, many preventable health conditions and mortality instances, such as heart disease, diabetes, nephritis, nephrosis. So we opted to also include obesity in this review.
Hi, the next question is for you. How do these different health issues affect the family? And how does marital and family therapy help in relation to these high mortality conditions?
You know, I think that is a great question and an extremely difficult question at the same time. I think that if we look at the biopsychosocial spiritual frameworks or lenses that we use in medical family therapy or as family therapists that are situated in healthcare, these illnesses, broadly defined, can impact the identified patient in any variety of ways. And we as clinicians want to connect the dots across those systems. But it isn't even that simple, because every identified patient inhabits a family, and every family member is also an individual with those biopsychosocial, spiritual complexities. And certainly the health, the illness, and the trajectories of that health and illness, the depression, the anxiety, the worry, the sense of feeling scattered, trying to navigate a complex system, all of those things are felt by everybody, arguably. And the impacts then, I mean, pick your illness, pick your impact. It's probably happening in some way, shape, or another with somebody. And I think that that connects to the second half of the question, because as family therapists, we lean into that complexity. We work hard to connect the dots, not only in terms of the complexities of those patients, but the families that they inhabit, to co-own the illness and to co-own the responses to that illness. We know that a lot of the things that contribute to and help in response to, again, pick the illness, are co-owned and co-felt and co-responded to if or as we allow it, or if or as we ask the questions to connect those dots. I think that along the way, the interdisciplinary complexity of the ways that we do care lends itself to the same types of systemic thinking. We as family therapists want to encourage, want to empower, want to help families navigate a medical system that can be quite daunting. And at the same time, by collaborating with all of these other disciplines, with all of our other colleagues across a variety of other health foci, we're able to ultimately do better work together that way.
Thank you, Tai, for that very complete response on a very complex issue and in such a systemic way. Now we turn to Dr. Jackie Williams Reade. Jackie, our article revealed that there was a dearth of research regarding high mortality conditions with children. What do you attribute this lack of research to?
Yeah, there definitely was a lack of, especially relational research for these childhood illnesses. There were some interesting studies that focused on like psychological effects for individual family members, but definitely didn't follow through with it, including all family members or families as a whole. So that was definitely lacking. So for instance, there would be studies about siblings and their experience when their sibling had an illness, but it didn't really account for the entire family's experience. So those weren't included. So there is research out there, but the relational research is lacking. I would chalk that up to a couple factors for the family on the family's behalf. There's kind of the emotional and then the practical illness demands. When a family gets a diagnosis, one of their children gets a diagnosis. For example, I worked on the cancer section. So if a child gets diagnosed with cancer, that entire family experiences a lot of illness demands. There's an intensive treatment schedule. There's high levels of distress due to the uncertainty of treatment outcomes. So families as a whole are adjusting to a whole new world, which includes cancer and all the distress that brings. So adding to their plate another place to go to do even an intervention, even though they need an intervention, the work it takes to get all of them to that intervention is just a lot, considering all that they're going through emotionally with adjusting to that illness. Also, practically, an illness brings with it a lot of demands that affect families differently, depending on their structure and their context. So when a child is ill, someone in that family unit, whether it's the smaller family unit or a greater family context, has to take on the role usually of the primary parent, the primary caregiver who takes the child to the treatments, schedules the treatments, works with the school if this child is going to miss school due to the treatments, really takes on all those practical demands of the illness. So again, it's really difficult to ask a family to take on all those demands, emotional and practical, the illness demands of them, and also include themselves in an intervention or in a research intervention. It's just a lot on a family's plate already, and this kind of research just adds more to that plate.
Jackie, thank you so much for all that you've given to the field in the way of pediatric research, and also this really important glance into what's happening in the area of oncology. I want to now go to Ms. Erika Taylor and ask Erika, based on our findings, what would you say are other areas that need more research?
I think what really stood out for all of us over the course of compiling the strategic review was simply the sparsity of well-established family and couple intervention research. Of the over 20,000 articles that we reviewed, only 87 of those met our inclusion criteria, but of those 87, there were no interventions found to be well established. And I think that simply reminds us as scientists, practitioners, and as a field collectively, in order to continue advancing the empirical base for these types of interventions, we need to be able to dedicate more time, energy, and resources toward the development and the rigorous testing of early stage interventions that are going to be grounded in theory and also mindful of couple and family inclusion throughout each stage of that development and implementation process, as many of you all have mentioned already. I think the other thing that we found as a gap in the literature and research was simply being mindful of the contextual details of the sample populations that we're recruiting and opting to include in this type of research. Much of our review indicated that a lot of underrepresented and minoritized populations were actually excluded from our samples overall. And when we look at that and we think about that exclusion of those very important populations, it really starts to further perpetuate some of the pre-existing health inequities and disparities that we already find embedded in systems of care and support. So I think as we continue to expand our research in these areas, it's important for us to be mindful of these tenets, especially as we continue to address behavioral and systemic aspects of what it means to be healthy and to achieve wellness in the current state in which we find ourselves.
Thank you, Erika, for reminding us of how many articles we all have read in preparation of this important publication, but also just sharing again with this audience the great strengths that we've already achieved and also the ways in which we can continue to move this research forward. Thank you so much for your contribution to this manuscript. We are now entering a lightning round question, my friends. So we're going to all just take about 30 seconds to respond to this question. What do the results of this research review mean for therapists? I'll kick us off and just say that therapists who work with families facing high mortality health conditions have a resource to rely on through this manuscript. It is filled with research that has included both moderate and high levels of family involvement in the design, assessment, and/or interventions that they can read about. I will toss it over to my colleague, Dr. Jennifer Hodgson.
I think that's an amazing response, Angela. I would just add that I think therapists could use this to also market their services in their communities, looking at some of these high mortality conditions and the specialists that oftentimes treat them. They could go in and share with them some of the skills, the systemic relational skills, the collaborative skills that they bring to help the providers really target those biopsychosocial, spiritual areas of health that patients want support with, but oftentimes can't be met in those environments alone. So I think our readers could really use this information to share their expertise and increase their visibility in their communities.
Okay, Tai, over to you. What do the results of this research review mean for therapists?
I think for therapists, again, we need to lean into the complexity. Most of our training is relatively by ourselves. And once we get into healthcare, into all the complexities, we need to collaborate with a variety of other health providers. We need to learn their languages. We need to get comfortable with a variety of different turfs that don't feel very much like the private practice context that a lot of our textbooks originally teach us in graduate school. We need to lean into the messy. We need to embrace the messy. We need to connect those dots.
Thank you, Tai, for that response. We will now be going to Dr. Jackie Williams Reade. Jackie, what do the results of this research review mean for therapists?
I think it means it's time to get creative. One of the interventions that I reviewed, which I thought was so cool, was they did an inpatient intervention. It was like 6 weeks, and these families moved into basically a housing unit. And so they had access to every family member. There were multifamily groups, there were sibling groups, there was family therapy, individual therapy, group sessions. They just did it all. And it really had a really big effect on those families. And while that is maybe a lot for the individual practitioner to do, I think now, especially with us being more accustomed to online therapy, there are a lot of ways to get creative in how you offer your services and ways to make it more accessible for families families so that more of these family members can come in, whether that's, coming in via Zoom or however, so that we can get this information, we can do these interventions, because we know the MFT community is doing great work. We just maybe need to get more creative and more accessible so that it can go out to the larger audience.
What a great energized response, Jackie. Thank you so much. We will now be moving to Erika. Ms. Erika Taylor, please help us. What do the results of this research review mean for therapists?
I think for me, it's fairly simple, and it's something that I am personally very passionate about, and that is simply advocacy and training. I think that this article really helps us to enhance and re-recognize how much we can do in the realm of advocating for our field, our discipline, our profession, being able to really leverage our skill sets and advocate for ourselves in the context of interdisciplinary teams, and also in health system science overall. So I think advocating and then also training the future generation of MFTs and MedFTs to feel empowered enough and knowledgeable enough to do the same.
Thank you, Erika, so much for your response. I could not agree more. I think that there's so much more that we can be doing in our training programs to be able to make sure that students understand about these interventions and how they interface with all of the health conditions that we may be seeing. I am so grateful as well for so many of your comments that really help us have a call to action, that we can think about the work that we can do in relation to incorporating more families into our research designs, into our practices as we're thinking about health conditions, and that we're also thinking about our underserved or underrepresented community, building the trust that is so needed to be able to deliver the best biopsychosocial spiritual care that we can throughout the lifespan. I am so grateful for all of your responses through that very quick lightning round. Thanks to all of you for joining me in this Decade in Review series and being part of this meaningful conversation on the current state of research around couple and family interventions for high mortality health conditions. It is our hope that this work will be valuable in continuing to advance the profession of marriage and family therapy. And thank you to all of our viewers for tuning in today. We hope you'll reach out with comments or questions. You can join in the conversation with us on Twitter by tagging @the AAMFT. Visit the link on the screen to read the article and more from our Decade in Review issue. Thank you for tuning in.